Thanks very much. My name is Zach, and I am going to talk to you about health inequities and disparities. I am from the Health Policy Institute of Ohio, but issues of inequities and disparities certainly cross interstate lines. Right? We could not do our work without the support of our core funders, including Interact for Health. So thank you very much for the support, and again for the opportunity to be here and talk about some of the new work and understanding that we're developing around health inequities and disparities, and some of the work we're doing with data to engage policymakers. These are the key takeaways from my presentation. I'm going to start by defining some equity terms, some health equity terms, talk about how policies contribute to and can advance health equity, and then share some HPIO tools with you. So to just set up how I'm going to define some of these terms around health equity, we'll use this research from County Health Rankings, which I think was referenced earlier. It confirms what most of us know to be true about health. It's about more than what happens in the doctor's office. About 20% of our health is attributed to clinical care, 30% to health behaviors, and then the other 50% is what's often referred to as social determinants of health, right? Factors in the social, physical, and economic environments that impact our health. And when we're talking about health equity, we're really talking about how differences in access to resources in the clinical care, physical, and social economic environments, how that impacts health for individuals and groups. So these definitions come from a CDC working group on health equity. Health inequities are disparities in rates due to differences in the distribution of social, economic, environmental, and healthcare resources. A good example is from lead poisoning. So people that live in housing that is older, less well-maintained, and in neighborhoods with lower median incomes are more likely to have elevated blood levels and then deal with the serious health consequences that come with it. Now, health inequities disproportionately impact specific segments of the population. And this is because resources in the physical, social, and economic environments and access to healthcare tend to be distributed along certain lines in our population. And those are lines of race, education, disability status, geography, gender, right? And the CDC defines those differences in health status among segments of the population as health disparities. When a health inequity contributes to a health disparity, there is an opportunity to improve health by advancing health equity. And to help HPIO in our work in advancing health equity, we have an advisory group, and they came up with this consensus definition of health equity. And for the people in the back of the room, I'll just read the first couple of lines. Health equity means that everyone is able to achieve their full health potential, and this requires addressing historical and contemporary injustices and removing obstacles to health. Well, this definition really brings me to the second key takeaway of my presentation. And just as a reminder, that's that policies can both contribute to inequities and disparities, and they can advance health equity. At this point in the conversation, it's really important to remember that the distribution of resources along lines of race, gender, class, education, disability status, in some cases geography, those distributions don't occur randomly, right? They're not natural. They're the consequence of policies and practices, both historical and contemporary, both intentional and unintentional, that give advantage to some groups and disadvantage other groups. And oftentimes, those policies are rooted in racism, discrimination, or other forms of oppression. One really well-researched example of a policy that is historical but has contemporary implications for both inequities and disparities is redlining. Redlining was implemented by the Federal Homeowner Loan Corporation in the wake of the Great Depression. That agency was charged with refinancing mortgages that were underwater in the wake of the Depression. Sound familiar? One of the tools that the agency provided to banks who were financing those mortgages was maps of neighborhoods, and this is Cleveland. And on those maps, they would grade neighborhoods based on the risk of financing a loan in that neighborhood. And neighborhoods with higher percentage of non-white residents typically were assigned a lower grade, meaning that refinancing would be more risky. One of the long-term impacts of redlining is housing instability. And this data, again from Cleveland, shows that neighborhoods that received the lowest homeowner loan corporation grade back in the 1930s, evictions are 3 times more common in those neighborhoods than they are in neighborhoods that had the highest homeowner loan corporation grade. Housing instability is associated with a lot of negative health outcomes, including poor self-rated health. It's also associated with poor birth outcomes and a lot of other outcomes related to chronic conditions. Now, redlining did not cause all of those evictions, nor did it cause the health problems that we see. But redlining is an example of one policy that created conditions in communities where housing instability is more prevalent than it is in other communities. And this is just a redesign of a flowchart from the Kirwan Institute for the Study of Race and Ethnicity that traces the short, medium, and long-term impacts of redlining on communities that received a low grade. But the good news is here, improvement really is possible. Implementing strategies that are proven effective at reducing health disparities in communities where the need is greatest can advance health equity. But to do this, we really need to target and tailor strategies to communities where the need is greatest. We need to have leadership from communities where the need is greatest. And we need to couple these with efforts to address the underlying causes, the racism, discrimination, and other forms of oppression. HPIO produces publications that match up data about inequities and disparities with information about policies that can advance health equity. And to do that, we consult with evidence registries that rate the effectiveness of various strategies to reduce health disparities. And then we consider that information as we write policy recommendations. So now I'm just going to show a couple of HPIO tools where we connect that data on inequity and disparity to policy recommendations for advancing health equity. The first is our health value dashboard. This is a tool that we use to track Ohio's progress on a set of about 100 metrics related to health. The primary finding from the 2019 health value dashboard was that Ohioans are less healthy and spend more on healthcare than people in most other states. On health value, which is a composite metric of population health and healthcare spending, we ranked number 46. Just to head off the questions, our neighboring states aren't doing much better. And what's happening here is we're summing Z-scores, and our very, very, very poor health is dragging down our health value in these states. One of the reasons we point to is that too many Ohioans are left behind. And this refers directly to the health disparities that I'm talking about today. To help engage policymakers, we disaggregate data in the dashboard, and this is something I'll encourage all of you researchers to be thinking about doing at the beginning as you're planning research designs. So in the dashboard, we disaggregate data by race, education or income, and then disability status. And we have metrics related to inequities in the social, physical, and economic environments, inequities in access to healthcare, and then information about the health disparities that we observe in Ohio. All of the strategies that we promote in the health value dashboard are rated as effective for reducing health disparities. But again, really important reminder, we can only reduce disparities if we are directing the resources and the leadership and the power to the communities where the need is greatest. Another example of an HPIO publication is Closing Ohio's Health Gaps. In this publication, we not only share the data on health inequities and disparities and explore some of the policies that perpetuate those inequities and disparities. In this brief, we introduce a framework for achieving health equity, and that's again adapted from county health rankings. And we provide specific examples of implementation from Ohio. And those are really important because they help policymakers to envision what advancing health equity can look like on the ground in Ohio. All right? So in closing, this is the framework, but in closing, I just want to say that we think that HPIO's approach of connecting data on inequities and disparities with evidence-informed policy recommendations is really one that any organization can recreate to help engage policymakers in this work. So I think we'll do questions now, but thank you very much.